Hello and welcome. My name is Elana Gordon. I am a reporter and producer at The World covering global health. This is a Facebook Live Q&A about predicting gaps in hospital capacity. And with me is Dr. Ashish Jha, director of the Harvard Global Health Institute. Hello.
Hi.
And also a professor of global health at the Harvard T.H. Chan School of Public Health, excuse me. You can post your questions for Ashish and me on Facebook, and that is at Forum HSPH and at PRI The World, or you can email them to the forum at hsph.harvard.edu. And this Q&A is jointly presented by the Forum, the Harvard T.H. Chan School of Public Health, and The World from PRX and WGBH. We're doing this by Zoom through Facebook, so thank you for your patience. And we'll continue to bring updates on this conversation throughout about coronavirus. So Ashish, I want to start the US right now. We appear to be really struggling, and we've described this federal response as deeply disappointing. And I want to get to some of these things, but right now it appears that the pandemic of coronavirus seems to be approaching the United States. We seem to be kind of at the beginning. I wonder if you can give us a pulse of where we're at.
Yeah, absolutely, Elena. And thank you for having me on. So we're this morning nearing about 500,000 people identified as having been infected with coronavirus around the world. And the pandemic, which started in China, and a couple of weeks ago, the World Health Organization described Europe as the epicenter. I think it's pretty fair to describe that the epicenter is now moving to the United States. America in the next couple of days is going to overtake Italy as the second most number of cases. And I suspect in the next 4 or 5 days, it'll overtake China as the country with the most cases. It might even be sooner than that. So this has hit us pretty hard. It's largely because we wasted 2 months. 2 months is a long time to waste in a pandemic. We knew in mid-January, I think, certainly by the later part of January, that the pandemic was going to hit the United States, and we didn't prepare. And now here we are with a whole host of challenges in front of us, all of which we can deal with. But time is not on our side in terms of getting going on these challenges.
You say we didn't prepare, and yet I want to kind of ask a little more about that, because as a nation, as a healthcare system, there is a deep kind of pride in leading so much around medicine, around science. So where is that disconnect?
Yeah, so look, we have the most dynamic scientific community in the world. We have an extraordinarily capable health system. It's got its challenges, of course, but it's a very, very good health system in lots of ways. And certainly for things like this, it is well prepared, or should be. But basically for 6, 8 weeks, we weren't paying attention to the pandemic. We weren't preparing. We weren't stockpiling the things we're going to need. We weren't getting our beds ready. We weren't getting ventilators ready. And then the biggest issue is we wasted 2 months not getting testing prepared and ready. And so we fell way behind. And what we're seeing right now are the consequences of all of that lack of preparedness. Again, we have so many resources, intellectual and financial, that I think we can still turn this around. But it's just a much steeper hill to climb now than it would have been had we gotten started 2 months ago.
I have to ask, just starting off, this stimulus package that came through, in what way do you see that helping kind of get back up to speed?
Yeah, so look, I haven't dug in deeply into the stimulus package. Obviously, a lot of it is about providing relief to Americans who have been very hard hit, and that's completely appropriate and necessary. There is some resources going to hospitals, and that's going to be helpful because a lot of hospitals are going to get into a lot of financial trouble over the upcoming days and weeks as they cancel a lot of procedures and then have to take care of a large number of COVID patients. But what we need is a broader response than what's in the stimulus bill. We really need a very aggressive response from the White House. And then we need aggressive responses from states. And some states have done that, and other states have not. And what's been most interesting to me on this is that this is not broken down around classic, red states, blue states. There have been some red states that have been fabulous. And then there have been other areas that are led by Democrat or liberal leaders have done a terrible job. So it's really been haphazard and hasn't fallen under sort of traditional political lines.
So how do you define great job? And as it relates to healthcare preparedness and
Right.
being on this.
So look, we have a couple of approaches. One is what we would have loved to have done 6, 8 weeks ago is built up a testing infrastructure, tested widely, isolated people who were sick. All right, water under the bridge. We can't do that anymore. So what can we do today? What we can do today is be very aggressive on social distancing or physical distancing, whatever you want to call it. Really putting a big pause on activity, only letting essential activity move forward. What that does is slows the spread of the virus. It gives the health system more time to prepare, and it actually gives us a chance to ramp up our testing so that we can unpause in a smart and scientifically driven way. Governor Mike DeWine of Ohio has been fabulous on this. Governor Cuomo has been very good on this. So it's just there are governors who are taking the lead, but it's a state-by-state effort. I would love to see a federal effort on this where the president stands up and says we need to take a national pause. I know he sort of said 15 days of less activity, but I wish he would really push all states to go to a true pause so we can do what we need to do to get ready for what's going to be a challenging battle. Let me just make one other point. This is not a virus that goes away in 2 weeks or 4 weeks or 6 weeks. We are going to be living with this in one form or another for 12 to 18 months if we are lucky. If once we have a vaccine that's effective and widely deployed, we can bring the pandemic to an end. Until that time, we are going to continue to have to confront and deal with the virus.
So let's say places literally hit pause. What is it that hospitals can do in that time? What is it? I know that you've researched bed capacity and things like that.
Yep.
What have you found, and what needs to be happening?
Yeah. So if we take the kind of worst case scenario of even a worst case scenario, let's just say a scenario where there is no pause, and there are a lot of estimates of what proportion of the population will end up getting infected. But if we kind of do a middle of the road scenario, 40% of the adult population ends up getting infected over a 6-month period, what we would find is that the number of hospital beds we would need to take care of all the people who would get hospitalized, number of ICU beds, would way outstrip what our capacity is today. We even did one model, and I'll just give you the numbers, where we said if every hospital emptied out half of its currently occupied beds, which is hard to do, but imagine they could, and did the same thing for their ICUs. If 40% of people got infected over the next 6 months, we would need 3 times as many beds as would become available in that scenario, and almost 6 times as many ICU beds as would become available in that scenario. So even in that very scenario where you have a lot of capacity creation, we would not be anywhere near where we need to be. So there are 2 points of this social distancing. One is to spread those infections out. You guys have all heard about flattening the curve. It's to give our hospital systems enough time to take care of everybody. But the second part is it also gives us time to make sure we have enough personal protective equipment and ventilators and all the tools we're going to need. Because if everybody shows up tomorrow to the emergency department, most hospitals in America are not going to be able to handle it.
So I want to start getting to questions that have been coming in, and this first one relates to this. It comes from Angus Chen, and one of the issues is, some hospitals are now freeing up outpatient or using freed up outpatient facilities and specialized hospital space for patients, or moving other patients there to free up space. And this might be in larger or other facilities. And so given the reality of it's a difficult situation either way, what do you think of these efforts?
Yeah, no, what's really clear is that just using our current space as it stands today is not going to be enough for a variety of reasons. One is, and again, some hospitals are working on this, is you want to try to actually separate out your COVID patients from your non-COVID patients, because you don't want the hospital to become a major source of transmission. Because people need hospital care, but a lot of people obviously are in without COVID, other people have the infection. So you often want to try to create different physical spaces if at all possible. And that has meant for some hospitals thinking about moving their non-COVID patients off, other people building new capacities, a tent in their parking lot, or getting a middle school or a high school that's been closed, or opening up an old hospital that was closed, and maybe trying to get all your COVID patients into those facilities. It's actually a pretty good strategy. Of course, all of it depends on having enough doctors and nurses. And that's the part that I worry a lot about. is that whether we're going to have adequate staffing and people who are protected so that they can actually take care of patients.
A question that came in actually through Twitter just before the chat had to do with the question about rural settings. And when you look at the US, I mean, could rural areas be protected a little bit just in terms of that spread, or how do you imagine then these communities building up capacity?
So look, we do think that the infection spreads up front a bit more rapidly in more densely packed settings. It makes sense, right? People are just rubbing elbows more often. So that is not a surprise. And that's why we've seen, I think, New York hit earlier. There's no reason to believe, based on the biology as we understand it, that somehow rural settings will be spared. The infections will come a little later. So instead of now or next week, it might be a few weeks from now, even a couple of months from now. But when rural areas are hit, they will be hit with a lot of the same challenges, and in many ways, new challenges. So they obviously tend to be, by definition, less dense. The calculations we've done have suggested a lot of rural areas may do okay in terms of hospital beds. Not great, but not as badly. But where they're going to get into a lot of trouble is around ICU care. The capacity of ICU care in rural areas in America is really quite limited. And when people get very sick and need ICU care, it's going to be very, very hard to provide all the ICU care they need. And it's not going to be easy to just put everybody in an ambulance and send them 3 hours, not when they're critically ill. And so I'm very worried about what's going to happen to the critically ill people in rural areas when the infection becomes more widespread there.
So this question comes from Wendy. In terms of your concerns, it leads to this really difficult scenario for healthcare, for doctors and nurses. In terms of what kind of criteria and factors then does one determine who gets these limited resources, in terms of the status of the patient, how ill they are, likelihood to recover, when we're talking about equipment like ventilators?
Yeah. Look, so there's been a lot on this from Italy, where doctors on the front lines have been having to make choices where people who are older, people who have chronic illnesses, people who are immunocompromised, because they will generally tend to do worse, they have often not been offered ventilator therapy. And by the way, if you have respiratory failure and you don't get a ventilator, you die. So it's not like you don't get the right therapy, but you get a different one. There's just whatever else we do, it won't work. And then there have even been instances of older people or sicker people who are on a ventilator, and people have removed the ventilator to try to then make that available for a younger or a healthier patient. I think these are awful, god-awful decisions. And I'm not criticizing the people who are making them. I'm very sympathetic. These are incredibly awful decisions. And I just don't know that we want every doctor and nurse to have to choose on their own. And so we need to start really creating some set of policies about how we will ration care. And I think we should put that word out there. We're going to ration care so some people will live and some people will die. And we should have some systematic approach to doing it. But of course, I believe much more strongly that we've got to do absolutely everything in our power to make sure that that doesn't even come up. I think it will, but there's a lot we can do to really minimize how often that comes up. And we're not doing everything we need to be doing right now to make sure that that issue doesn't even come up or comes up much less frequently.
And remind us again, those things to do to minimize.
Yeah, so look, there are a couple of things. I mean, if you look at ventilator capacity, just number of ventilators, again, their numbers differ, but we have somewhere between 60 and 160,000 ventilators. There's some estimates that we might need 400,000 or 500,000 ventilators. We almost surely can't ramp up enough. We could have 2 months ago, but we can't ramp up enough to get all of those. But we can do a lot. We can ramp up a lot of ventilators. I believe very strongly that the president should use the Defense Production Act to actually start creating, getting companies to start creating ventilators. It still won't be enough. One of the things that's good about this disease, to the extent that we can see this as a good thing, is that the disease is not going to hit every community at the same time. And so there's a real role for federal coordination around the idea that if New York needs 30,000 ventilators now, maybe other communities can send their ventilators to New York with the promise that when the disease hits their community, those ventilators and other ventilators arrive in those communities. This is how we get through this together. If every state and every community fights to maximize its own ventilators, we're all going to be in trouble. But if we can work in a coordinated way, we get through it much easier.
And what's the best way to coordinate?
This is challenging. And what's the right mechanism? We have a piece out in the New England Journal that came out last night where we call on the Department of Health and Human Services. You can imagine Medicare or CDC or some other federal agency, the White House. But it has to ultimately be done by the federal government. I've been talking to other folks about who else could play a coordinating role. You can imagine a consortium of states could decide to share. But this is why we have a federal government, is that we need it to play a coordinating role in moments like this.
I want to get back to stepping outside the doors of the hospital for a moment. And when you talk about we need to take a pause, we need to do social distancing, there's a question that comes from Rick about what members of the public can do to protect themselves and their communities if they're aware of an expected shortfall in hospital capacity. I guess I'm making a connection to what you were talking about earlier about distancing. So I have two questions. One comes from Rick, like what can the public do knowing that there's this issue? But also, I wonder if you could also clarify a little more. Social distancing, to me, and a lot of people can kind of lose sight of like, what does that actually mean? Like, what does that really actually mean?
Yeah. All right, so let's talk about what social distancing actually means. And again, as I said, some people are really pushing for calling it physical distancing. I think it's fine, whichever term you use. The notion is the virus can't spread from one person to another unless those people are in contact with each other. There is some evidence that it could spread by surfaces. I can come back to that if people want, but I don't think that's a major mode of transmission, or not that we know of. And so if imagine, I'm not suggesting this, imagine we took every single American and locked them in a room by themselves. After a few weeks, the virus would just go away because it would run its course in each individual person, and then it wouldn't have anybody to spread it to. So obviously we're not doing that, and we shouldn't. But so then the question is, that's one extreme. The other extreme is let everybody mingle as much as they want. And we want somewhere in between. And the closer we are to fewer interactions, the more the virus slows down. And so if you're not hanging out in a coffee shop and rubbing elbows with your buddies at work or at college or whatever, you're just not spreading the infections around as much. And so it slows down spread. It may mean that we end up still with the same number of infections in the long run. That's debated. But if you do it over many, many, many months, then as people get sick, the hospitals will be ready to take care of them. A simple way that I sort of describe that spike issue is, if 1,000 people show up to the emergency department today, that emergency department is going to be very challenged. But if those same 1,000 people show up over 2 months, the emergency department will be able to handle all those people, right? Because it's about 15 people a day. So that's what we want to do, is we want to give our hospitals a shot. And again, the more we spread it out, the more time we have for testing therapies, the more time we have to have a vaccine. So there are lots of benefits of delaying how quickly this infection spreads throughout our community.
This question kind of brings it's from Tim, back inside the hospital in some ways. There's this 6-foot distancing sort of recommendation between people. Is that beneficial? But also when you think about in hospital settings, in patient rooms, how does that translate?
Yeah, it's very hard, right? And obviously in a busy emergency department, the idea that somehow everybody will keep 6 feet from everybody else is unrealistic. And some people say it's not even 6, it's probably more like 10, because if you sneeze, those droplets can end up going further. And the way I look at this is that there's not a rule that says, like, the more distance you can do, the better. Beyond 10 feet, you probably don't need to do that much more. But in a hospital, that's unrealistic. So even in a hospital, I would say that staff probably should not be giving each other hugs. Not right now, later, once this disease is over. But there's some basic stuff, people should be washing hands pretty regularly. My sense is that's happening across hospitals. When you go into a room of a patient who might be potentially infected, really suiting up and assuming that that person has COVID and trying their best. Will that all be perfect and completely stop transmission within hospitals? No. But could it dramatically reduce the infection rates? Absolutely. And so there's a spectrum here, and we're just trying to push as much as possible towards less transmission, less spread, slower spread. The things we'd need to do to completely halt spread anywhere, including hospitals, I would get a little bit untenable. So I think what I'm seeing in most hospitals is people trying to create more distance, trying to suit up as much as possible, washing hands, getting rid of some of the basic human stuff that we all love. Like some people are huggers and some people like shaking hands. None of that right now.
So I want to go to just a variety of questions that people have been putting in that kind of span some things that it's just with a deluge of developments and still unknowns.
Yep.
One question comes from online, which is, are you seeing the US having higher, quote, positive rates than other countries? And why might that be?
Yeah. Positive rates are hard to interpret because they're, of course, completely dependent on who you test and how extensive your testing is. And what should our positive rate be is also a hard question to answer. When I look at a place like South Korea, which did a very good job on testing, their positive rate was about 3%, suggesting that about 97% of people tested that didn't have the infection, at least not at that moment. That's another way of saying they cast a wide net. I believe we should be casting a wide net. Our positive rate is, I have to kind of look up where we are this morning, but I think it's like 20-25%. What that says to me is we are not testing enough people, and we are not casting our net widely enough. And that's very simple. Why? It's just our testing capacity is still quite limited. We are not where South Korea was in terms of tests per capita. So the president touted that we're doing more tests in South Korea. That is correct. But per capita, we're doing fewer tests still. But we're much further along in the infection, and I suspect that our testing numbers have to rise pretty dramatically till we get to a point where we've cast enough of a wide net that we're getting a lot of negatives. Of course, also the social distancing stuff we're doing should slow things down and allow us. So I do pay attention to the positive rate. I don't have a magic number, but I worry a lot about where America is right now.
Do you worry, this question comes from Facebook, with kind of being on the early part of what it appears to be infections in the US and what's coming to hospitals as predicting the capacity? It seems like there would be a big secondary healthcare demand that would follow, for example, with things like cancer treatment and cardiovascular disease. And so what do you see for like how to deal with the displaced healthcare of those things?
Yeah, I've been out there saying we should cancel all elective procedures and we should expand our definition of what elective is. So we're only doing things that are truly, truly emergent or highly urgent. But those things that we're canceling still need to be done, and they're still clinically important. They're not unnecessary, right? So the woman who might have really severe hip pain and badly needs a hip replacement, we can delay it for a couple of months. It will be painful and there'll be suffering. But at some point, there's going to be a huge amount of pent-up demand. And the healthcare system's going to have to deal with that. And when and how to get that in, this is going to be a very big struggle because we don't really know how this disease plays out over the next 6 to 12 months. It depends a lot on what we do and how well we do it. But in between all of that, we're going to have to try to squeeze in a lot of this quote unquote elective stuff, because maybe you can ask people to wait a couple of months for a surgery they needed today, but we probably can't ask people to wait 18 months for a surgery they needed today. And so at some point, we're going to have to figure out how to work these things in. No easy answers on this. It's going to be a challenge.
And this question comes from Riganka, and it touches on some things that you've mentioned before, but again, when we look at the scope of needs of hospitals and the healthcare system during a pandemic, what's being dealt with, what are the most urgent things right now that need to be dealt with? Like personnel would be one thing, and how do we support them?
So most urgent in the hospital or kind of overall in the country?
In the healthcare capacity.
In the healthcare
system.
I
would ask to kind of take that in two parts to look at both.
Yeah, so the way I think about this is we're now in kind of a multi-pronged, but let's talk about two of the prongs. One is the public health system, and then the other is the healthcare delivery system. And they have an intersection, and they obviously are totally interrelated. So let's talk about the healthcare system itself, the hospitals, doctors, nurses. And by the way, whenever I say doctors and nurses, I am fully aware that there's a whole host of people, respiratory therapists, but I don't want to have to say the whole list every time. So I use doctors and nurses as a shorthand, just to be clear. So in the hospitals, there is a surge happening in New York. There is a surge happening in a couple other places. And you can look at the data and you can start seeing where the next set of cities and states are. I am deeply worried about New Orleans and Louisiana. I think they're going to get hit very hard in the upcoming days and weeks. There are other places that I'm really worried about. just based on the data. What they need is, from a priority point of view, is we need doctors and nurses ready to go. We need them to be healthy. We need to protect them. We need enough kind of capacity, beds, ventilators, personal protective equipment, enough medicines, enough of all the supplies. Because when patients arrive, we need to be able to take care of them and get them through this illness. So there is a set of high priority efforts that hospitals need to really engage in. Over the longer run, not even over the long run, the other part, on the public health side, and I'm going to call this part of public health, we need a substantially ramped up testing capacity. So we are testing, 70, 75,000 people a day for the last couple of days. I don't have a great number, but I think we need probably 2 to 3 times as many tests being done. That means
2 to 3 times.
2 to 3 times.
And any certain kind of test?
Testing in terms of testing people for the infection. And there's a whole bunch of different tests. And we're moving towards more rapid testing, and I think that's great. And the reason I took it out of the healthcare system is I don't want people going to their doctor's offices or emergency departments to get these tests, because that actually has a whole bunch of downstream effects, like using up personal protective equipment. So we need to set up testing centers and places where sick people can go. Then we need a big public health workforce that identifies people, traces their contacts, and then we have to do this all on a technology platform. It's just too many people to sit down and do long interviews and go trace everybody. We have to use technology as our friend here. And again, Singapore has built some nice technology. South Korea has. Obviously, we have some fabulous technology companies in the United States. We can do this. So that's the urgent priority on the public health side: testing, tracing, isolation. And there's a bunch of policy issues. Like if I got tested positive today, and they showed up and said, you need to be isolated for 2 weeks. Where am I going to go? I mean, I could go probably isolate in my own home, but imagine that I couldn't, or I was a poorer person, hourly wage worker. You could imagine what would happen is you need to help house those people, give them enough resources that they could get through the next couple of weeks. So all that is policy stuff. That's the public health side. And then the hospital side: protect doctors and nurses, get the equipment, set up the beds, and help people get through the acute illness.
When you talk about public health capacity, how is the public health capacity when we look at, you've hospital bed capacity, but what about those contact tracers?
Yeah, it's really hard to measure. We don't have great data, or at least I'm not aware of great data on public health capacity. I think one of the things that we believe is that if you look at how public health has been funded in our country, that's another way of saying how inadequately it's been funded in our country. I don't think most states have the amount of capacity they need to really put in a true testing, isolation, monitoring infrastructure. The bad news is we have a lot of people who have lost jobs recently. I think we should try to figure out how to get some of them employed and engaged in the public health infrastructure to try to help build up public health capacity, so that we can actually have a national monitoring program around this disease and its spread.
And, we're getting ready to wrap up, excuse me. But one of the things that I wanted to ask, and this has come up in a few different thematic ways, and given that your perspective in global health, it seems that the healthcare system in the US is different, very different from some other countries, for example, in Asia and Europe, in terms of its decentralized structure. And I wonder in what way that creates a disadvantage, but also how there might be some unique opportunities in that space too.
Yeah. I don't know if the healthcare system is that much more decentralized than, obviously places like the UK, we tend to think of as having a pretty centralized system, even though there, a lot of the decision making is very regional and local. But across a lot of European countries, healthcare is very much a kind of a county or a state level business. There is maybe a bit more central coordination than we have here in the US.
In terms of funding, though, too.
Yeah, well, yeah. Again, it's let's just say there's a lot of variation across Europe.
Okay.
That said, there are some unique challenges and some unique opportunities in our federalism kind of structure. Hospitals, doctors, all of that get licensed at the state level. It does set up a lot of challenges in the sense that different states are working differently on how prepared they are. And again, I've called for and hoped for a bit more national coordination, federal coordination on this stuff. And that's not because I don't want states to have the lead. I'm happy to have states do great stuff. It's not every state has capacity. Not every state can do the analytics. Not every state can really figure out what its needs are. And to be perfectly honest, not every state is taking it as seriously as they need to. So more federal effort would be really helpful. But the flip side is, and this disease outbreak has shown us, that when the federal government fails, when it fails to do its job effectively, states can step up. So the federal government really has done an abysmal job on setting up the testing infrastructure, and a lot of the progress we've made is because states have actually stepped up and built up their testing infrastructure. If we were fully and completely only dependent on the federal government, if every decision on distancing, on testing, on hospital capacity had to ultimately go through the White House, I'm not sure that we would be in necessarily much better shape. And so there are advantages of federalism. There are advantages of letting states do things. In a pandemic, I would much rather take a strongly coordinated federal response. But that said, here we are, and some states are going to do a better job than others. And I worry about the states that are going to do less good of a job.
And finally, what about when it comes to you mentioned technology for tracing, but what about when I think of the whole medical innovation space? Do you see some opportunities there?
Yeah, I know I mentioned this in passing, and I mean no disrespect to the scientific communities of other countries, but America's scientific community really is unparalleled. It's phenomenal. And the way we're going to beat this disease is through the work of our scientists. It's a reminder that science is the backbone of all of this stuff. And the amount of innovation, ingenuity, creative stuff, energy that I'm seeing in the scientific community, just in the Boston, Cambridge area, but I know it's also happening across the country, is fabulous. It's probably one of the big things that gives me hope that all the modeling and all the big scary numbers may end up being better than that because the scientists are going to come through with stuff. But of course, science is hard and takes time. And even though everybody's working very, very hard, I don't see a cure around the corner. There's probably no cure. There may be treatments that will work. I don't see a vaccine around the corner. So despite all the fabulous work, it is going to still be a bit of a slog until we get there.
Well, I wanted to just give you a chance to wrap up and see if there's anything else that kind of, as you move forward, as you're keeping your pulse on what's happening, where you're looking next.
Yeah. So let me say a couple of things. I mean, we are still in the early days of this pandemic, and there is a long path ahead of us. And whether the path is not going to be super smooth. There's not like a return to life in 2 weeks and everything will be great. That path I don't think exists. But the paths that do exist in front of us, one could be a pretty horrifying, lots of people dying, big economic calamity. Or it could be some bumpiness, a little bit of uncomfortableness, some economic harm. Some people end up getting sick, but we get through it without too much damage. Which of those paths we choose is really up to us. And so for people who are out there going, well, I'm not a doctor or a nurse, I'm not a public health person, what can I do? This is where we need our elected leaders. And while we look at the White House and we look at the federal government as part of it, Congress, I think, has not played as aggressive of a role on this as it needs to. And so talking to members of your Congress, your members of Congress, looking at your local and state officials and pressuring them to do the right thing. And then, of course, trying not to become a vector of this disease and trying to make sure you're washing your hands, staying away from people, playing your role. Those are all enormously helpful in getting us through this process. There's not fate here of how this is going to play out. It is really up to us to decide how this pandemic plays out.
Well, Dr. Ashish Jha, thank you so much for your time and insight.
My pleasure.
And so I'm going to wrap things up and say that concludes our Facebook discussion about healthcare capacity and so much more with COVID-19. This Q&A has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and The World from PRX and WGBH.